Hello, everyone. Apologies for the delay. As caregivers, we know that stuff happens, and the stuff that happened tonight is a little bit of technical difficulties. But here we are, and we are going to have an incredible event for you. Uh, if you've been joining us for the CALM, Caregivers Are Learning More conference sessions, welcome back. If this is the first one that you've been able to join us for, welcome, and be sure to watch the replays. A lot of great stuff. Now, all throughout November, the USC Family Caregiver Support Center is celebrating you and November's National Family Caregiver Month with all of these CALM conference sessions. I'm Paulina Milana, here to guide you through what we have in store for you that speaks to this year's theme of the art of balance. Now, this is the 24th year that the Los Angeles Caregiver Resource Center is presenting its special suite of events, meeting family caregivers wherever you may be in your caregiver journey and helping you navigate your path with tools, education, support services, and so much more. I encourage you to explore what we have to offer by visiting our website, and you'll see the URL on the screen. It's losangelescrc.usc.edu. Now, a little more housekeeping here. In today's session, I am sure that those of you watching are going to have questions, you're going to have comments, you're going to have stories of your own. And we encourage you to put those into the chat. And at the end of the session, we will take those questions and get you some answers. Also, every family caregiver that you see presenting today, they are authors of a book called the Caregiver Chronicles. And Los Angeles Caregiver Resource Center is making it possible for you to maybe get one of those books for free. We've got a random drawing going, and all you have to do is post on your social media some tidbits that you might hear that resonate with you during any one of these sessions. You can invite friends to come and join if you like. But whatever it is you do, make sure that you tag us and then take what you've got, take a screenshot of it, and email it to us at lacrc-calm@usc.edu. And we will enter you into that book drawing. Now, today's session is all about balancing those transitions, right? It's going to be a bit challenging maybe because every caregiver goes through it. We are grappling with doing it all ourselves, and then, oh gosh, realizing that maybe your care recipient, your care partner might need more than you can provide. And then we've got to explore, well, what does that possibly mean? Right? What's out there? What are the things I need to know? All of this, the how to is challenging enough, but it also conjures up thoughts and emotions and all sorts of feelings that can also be quite challenging. And we're going to talk about all of that today. So, before we get started, if you are actually experiencing saying goodbye, balancing these transitions, if you are starting to grapple with some of these things, or if perhaps you already have, please in the chat, go ahead and give us a word or a phrase that shares what you're thinking or how you're feeling about today's session topic, right? We want you to do that because we want folks to know you are not alone. You are not alone. And while our experts will present a lot of information that addresses a lot of the concerns and the how to's that will help us navigate our journey, we're actually going to start off with folks who also know they are not alone because they are actual family caregivers, experts in their own right, who had the courage to tell their stories in that book that I mentioned before, The Caregiver Chronicles. So we've got today with us Shanice, Terry, and Tanya. And I am going to ask each of them when they come on the screen to introduce themselves, tell us a little bit about the chapter that they wrote, the stories that they are sharing with us, the experience that they have had regarding balancing transitions, saying goodbye, and all of that I am sure is going to resonate with all of you. So let's get started. You didn't come here to hear me. And let's get going with Shanice, and then we'll bring on Terry, and then we'll bring on Tanya. So Shanice?
Hi, everyone. Yes, my name is Shanice, and am, I was the proud caregiver of my grandmother. I wrote chapter 7 in the book, The Caregiver Chronicles. Okay. In chapter 7, I discussed my journey of being the primary caregiver of my grandmother. Um, for me, my caregiving experience started at a very young age, at the age of 13, once my parents passed away. So, um, we I share a story where in her way that she was tired and she was ready to go. Um, However, all of the emotions that come along with that, the anger, the not ready to let go, the grief that I knew, the grief cycle.
And those gremlins continue to to work with us tonight, or work against us tonight. Shanice, you keep on kind of glitching in and out. Can you hear
Oh
me?
no, I am
Yeah.
able to hear you.
Hmm. I wonder if, are you in a place where your internet is pretty stable? Do you need to maybe shift a bit, or
It's
hard
generally
connect? Because we can go to
stable.
maybe Terry and Tanya, and then we'll come back to you.
Yeah, let's switch to Terry and Tanya. I'll try to reconnect a
Ah,
different way.
thank you. Thank you. Apologies to everyone. But again, as caregivers, we know the drill, right? Stuff happens, and we just kind of respond to it, right? So let's go with Terry.
Hi, everybody. I'm Terry Wellbrock, and I wrote chapter 21, The Addicted Angel. And my story really revolves around my relationship with my mom, who was an alcoholic, a severe alcoholic. And when I was a teenager, I remember her coming home and saying, I decided to donate my body to medical science. And as a kid, I was like, what the heck does that mean? But as we progressed and as she aged, and we started to have conversations about power of attorney and medical power of attorney, uh, she explained to me that she had donated her body to the University of Cincinnati um, medical school, and that when she would pass, then they would be able to um, research using her. And I thought that, gosh, that was such a selfless act. So when she received her diagnosis, her terminal diagnosis, um, and she made the decision, again sat down together and talked it through. And we worked with the Council on Aging in Cincinnati, where she lived. She made the decision to bring in home hospice. So she ended up in a facility in the end because of a fall. Um, but it was such a beautiful, beautiful transition for so many reasons, because one, she was really looking forward to the fact selflessly that she was going to donate her body. The other thing that I wanted to share was in our goodbyes, my sister had been distanced from my mom and their relationship. And when my mom ended up in hospice, my sister showed back up. And so we were able to sit with her and sing songs from our childhood and play her favorite church music. And we had family come and friends come, and a cousin made her ribs and she was able to eat some ribs. And so in the end, it was just a gift for me to spend those final 2 weeks with her, sitting by her side in that hospice room, and bring her all of the joys that she wanted to have. When she passed, she took her final breath, and this huge smile showed up on her face, as if, I don't know what she was looking at, if it was my dad or somebody else welcoming her. But I knew that she was leaving this life in just a very joyous way. So thank you.
Incredible story. Her chapter is definitely one that will resonate with those of you going through the same thing, or who might be going through something in the future. Um, Loved her chapter. She also, her podcast, tap into that, because it is something that you can check out, and on almost a daily basis you can hear more from Terry, and more from stories that she shares with her audiences. Thank you, Terry.
Thank you.
And so let's go to Tanya.
Hello, everyone. I am Tanya. I am the author of Chapter 8, Called Regret. You know, I had decided I was not going to put my mom in any type of facility, that she was going to live with me and I was going to take care of her, because that's what children do. They take care of their parents. After a month or two, I realized that I was way in over my head, and I started looking into different facilities and how to go about doing that. And, I'm not going to lie, honestly, it was very overwhelming. And, I was researching, Google is your friend. So I was researching on Google, and most of the information I was finding was contradictory, and a lot of it was incorrect. Um, so unfortunately, my mom's illness, she rapidly declined, and she did wind up going into a facility, and on hospice, and she passed away. But at the point in time when I was actually looking and trying to figure out, there were all of these emotions: guilt, regret, sadness, fear. I every emotion you can possibly imagine, including almost kind of a relief, thinking that I wasn't going to have to be responsible for so much anymore. Um, I something like this would have been really helpful for me, understanding exactly what I needed to do. The transition of my mom when she passed, it was very difficult, very hard, and I'm super thankful for the time that I had with her, and I am very glad she was with me, and I was able to spend that quality time with her before she passed on.
Yeah. And Tanya, I mean, you used so many words that I think resonate with a lot of caregivers, right? The grief, the regret, even sometimes the relief, right? When you can um, possibly find help, support, etc. Uh, and what I love about both of you and what you shared is that we have the entire gamut, right? From the regret and the in over my head overwhelm, to the oh my gosh, what a gift this is, to be able to spend these last moments while my loved one is transitioning. So beautiful. Again, great work, and thank you so much for the courage for sharing your story. And Shanice, you're back. So let's hope that the gremlins, the tech gremlins, are not going to cause us any more problems.
Okay, I believe. Are you all able to hear me now?
Yes.
Yes.
Okay, awesome. We're just going with the flow here. But my name, my name is Shanice, and I had the pleasure of working on this project, or the Caregiver Chronicles, with the other 21 care providers, and I had the opportunity to share a story in caregiving. You have a lot of stories, right? Especially with someone that has memory challenges. Oh, the stories that you have. But I decided to share a really large challenge that I faced, which was placing my grandmother in a facility. Um, I promised her once we put her in hospice, I would keep her at home until there was no until. I would keep her at home. However, like Tanya shared and Terry expressed as well, it is a lot of work. It was a lot of work as a young adult at the age of 19 that came with a lot of sacrifices. As the primary caregiver of my grandmother, my parents passed away. She had siblings, but they were elderly. It was just her and I. And it got to a point where I was probably on day 3 or day 4 of no sleep. And she faced sundowners pretty bad. And in my chapter, I talked about the mix of emotions that went along with the decision to ultimately place her in a respite. She was in hospice, so we were going to just do it for a short period of time. But right at that decision making point, she gave me something that I needed to let me know that it was okay. So I share that story in my chapter, the challenges that I faced and the dialogue that I had with myself and ultimately coming to that decision. And like Terry and Tanya, in hindsight, I am very grateful for the experience that I had, the time that I had to share with her um, during those last couple of weeks. An unbreakable bond is what I like to describe what we had, and it ultimately came to having to choose preservation in the end. So yeah, that's what you'll get when you read my chapter.
Yeah. Yeah, wonderful chapter as well. And again, caregiving, we come to caregiving all sorts of ways. Either we straight out choose it, or we become kind of perhaps reluctant caregivers, right? We don't even know what's happening. It can come at all sorts of ages. Um, and, Shanice and what you had to say about um, the challenges, not just with knowing, what to do and when to do it, et cetera, right? The nuts and bolts of it, but the challenges with
Mhm.
yourself in this journey. Uh, so, um, what I'd like to ask is everyone who's listening, if these stories are even, kind of starting to resonate with you, you're starting to think to yourself, "Oh my goodness, I'm going through something similar. I have gone through something similar. I'm worried about going through something similar." Just type, me, the word me in the chat. Again, you are not alone. And you're going to start seeing that you definitely are not alone. Um, Now, what we want to do is start talking about some of the expertise, some of the insights to help us along this caregiver journey. And we're going to start talking about palliative care and hospice. And to do that, we have Anne here with us. And I'm going to ask Anne to introduce herself first and then to let us know everything that she knows, not everything, but what she is going to share with us that's going to help us on our journey. I also want to share that Anne too is one of the authors in the Caregiver Chronicles, and so maybe you could speak a little bit to that from a personal level as well.
Yes, hi. Thanks for all of you for being here. I'm a palliative care social worker, a psychotherapist, and I've been working in the field of the medical field for a very long time, for a few decades. And I am sort of, I guess, one of the reluctant caregivers where I'm been doing my job for a long time. I'm an expert in palliative care. And then all of a sudden, my husband was diagnosed with stage 4 cancer that's non-curative. So I decided to write my story here with the book. It's my chapters Adjusting to Now, which essentially, when I wrote the book, the chapter was really showing just the change of having a diagnosis in the family, trying to navigate that. And a lot of it was the uncertainty about the future. Since writing that chapter, I've now helping my husband who has the cancer that's now progressed to his spine, and he has a lot more challenges, and we're facing new decisions. So this topic of palliative care and hospice is very close to home to me as well as professionally. So discussing palliative care and hospice, a lot of people have a misunderstanding of what palliative care is. And what I find a lot of times, our doctors don't know the difference. I did a training with a group of doctors, and I asked, what is palliative care? And they said it's comfort care when a person's at the end stage, which is not. So hopefully this talk can really help figure out what the terms mean, and then going forward, what supports are available to you. I like what the caregivers were saying about the transitions, that we want to keep our loved one at home. We want to provide the care ourselves, but that's not always possible. And I think the idea of transitions with caregiving is really a central part of it, that nobody wants to say goodbye. Some days I'm sure we all say, oh, I wish this was over. But really, truly, in the heart, we don't want to say goodbye. But the fact is, every day, all of us are saying goodbye. I think about autumn and the leaves changing, and then, the leaves falling, and it's just different seasons. And we fight goodbye, but we're saying goodbye every day to so many things in our lives. And as a caregiver, there's transitional goodbyes where every day you're seeing changes in functioning, you're seeing changes in yourself, what you're able to do and not do. And as you're moving along the journey of healthcare, this is where the transitions become important to talk about. What I find is that when I work with people who have a lot of grief after the loved one died, it's oftentimes because they didn't do their work ahead of time. When they're honest and open to talk about the different the different feelings and emotions, and being honest with what they're able to do and not do, their grief is a lot easier towards the end. So maybe we can start the slideshow. So are palliative care and hospice the same thing? If you think they are, type yes in the chat. And if no, then type no. And we'll see at the end, what people are at. And then the next slide. So are palliative care and hospice the same? This is a grid, we call it the butterfly model of palliative care. Palliative care emerged from the hospice model, where in the 1980s, hospice came on as a distinct medical care for people in the last stages of illness. And we're going to talk about that. But what we found was in the last stages of a person's life, they had a lot of challenges. The caregivers, the symptoms, the psychosocial, emotional, spiritual distress of the patient, all of that was happening, and they had a wonderful team model to provide that care. But what we've started finding in the medical community is that wasn't enough. A lot of people have the same stressors, the same questions, the same pain and symptoms and caregiver burden, much higher upstream. When the person isn't terminally ill, they're just either starting out with a new diagnosis, or as they're going through curative focused treatments, or with patients like that have dementia, the long goodbye, it could be a very up and down for a very long time, where they're not hospice appropriate, but they have the same needs. So palliative care emerged as a distinct model where it's made up of a team of a physician, a social worker, a chaplain, a nurse, pharmacist, other professionals that help really focus on comfort. The palliative care term comes from the Latin word to palliate, I can never remember it, but to palliate means to cloak or to comfort around the person. And that's what we try to do with our families. So once you get a serious life-limiting illness like dementia, Parkinson's, cancer, liver disease, cardiac, many different things, you're either getting a new diagnosis, you're wrapped up in doctor's appointments, trying to figure out what's wrong, you're starting to go through treatments. As you're progressing through the illness, from the very beginning, palliative care can be helpful. You're going through the different stages, and then some people do really well, and they end up graduating into a rehab type of focus, where they move from palliative care to also getting home health, physical therapy, and then they're out on their own. Maybe they are in remission now. So palliative care may start as support for serious illness and wind up with a graduation. of sorts. Other people have this serious illness and their illness progresses and the stages require more and more care, which then moves to the end stage of a person's life. And that's where we transition to hospice. Palliative care is a broad overview of beginning of diagnosis to end of life or cured, or remission or being cured. Hospice is a small part of that, but palliative care is throughout the whole stage. And then afterwards, after at the end of hospice or palliative care, we go into survivorship or bereavement, which palliative care and hospice can provide bereavement services too. So what is palliative care? It is a type of treatment, as I said, disciplinary. We look at a holistic model because a lot of times you'll go into the doctor's office and you say, I have pain or I have nausea or, backaches or whatever. And it's not really addressing all there is to that person. But in a 15-minute visit, the doctor says, have a pill or do this exercise, and then you're on your way. And the symptoms might, continue to reoccur. A lot of times with my team, we meet together for a half hour to an hour with our patients, with the social worker, chaplain, doctor, nurse, and we all look at our own separate disciplines, saying what is going on with this person and their family. I have a patient right now that has frequent UTIs, urinary tract infections, and so obviously the doctor's there to help support and treat that. But when we dug a little deeper, it's the wife said that she's having trouble turning the patient because he's so large. He's not able to help with the turning. She's only one person. It's the middle of the night, so he's not getting the changing or the the care that he properly needs, not because she doesn't want to, but because the care has become so significant. So yes, it's a medical condition, but it's also sort of a social condition that the caregiving needs to bump up, or there needs to be medical equipment or different things. So, and then we look at the sort of the existential part, like, why is this happening? How do I make sense of this? How do I navigate this where I'm thrown into this and I don't know what to do? And so palliative care becomes support where we can be sort of a roadmap and a team to advocate for you and to provide extra support. I'm having trouble reading the slide, so there we go. We provide strong symptom management because the physical is an important part of it. And doctors tend to look in their own silos, that if I'm a cardiologist, I'll treat the heart. If I'm a liver specialist, I'll treat the liver. If I, am chronic pain, I'll treat the chronic pain. And nobody's kind of putting all the dots together. So palliative care looks at the whole person, but the physician looks at the whole picture and says, what's the liver doctor saying? What's the cardiologist saying? What's the oncologist saying? And how can we make sure that everybody is bringing this whole person together rather than it just being this, bifurcated type of care? We assist with discussions about the future because a lot of times I find caregivers and patients get kind of caught by surprise, even though they may see things coming and progressing. When you're in the day-to-day, it's really hard to see the forest through the trees, right? So we take a step back. We say, okay, let's go back. Who are you as a person? What is important to you in your healthcare? And given that, what's reasonable in terms of the types of treatment that are being offered to you? What's reasonable that you're able to do? What do you need more support with? And if your illness changes down the line, would things change? We talk about the line in the sand, and that's where, yes, I want things right now. Like if my heart stopped, I'd want CPR. If my, if my cancer was, my husband's cancer continues to grow, we want all these chemotherapy and radiations and stuff. But at what point does that shift? And that we talk about quality of life where, for example, with my husband, he wants to be at home in his last days. He does not want to be in pain. So at what point do we say the chemotherapy or the radiation is more burdensome when the outcome is that he will still die versus continuing those things, knowing it might cause suffering and pain right now, but the outcome is going to be better. So palliative care addresses those things, as I said, in a whole person model. And the most important thing to me as a palliative care specialist is to really look at the person as a person first and not as a patient. Because you're going in, I'm a caregiver, I'm a patient. When we have those labels in our medical care, that's how we're treated. When we learn who you are as a person, the decisions that you make more sense. And so that's where we really want to start. So the benefit of palliative care, you're the patient, you're the loved one, and you're not alone. And I think from Terry and Tanya, and the stories here, these are really the feeling of being alone. Yes, I want to keep my loved one at home. I don't want to put them into placement, but now it's becoming too difficult and too stressful. So having a place where you can kind of talk that out, prepare for it, so you're not caught by surprise where all of a sudden I want to keep them at home, but now we're going into the hospital and the discharge planner is saying you got to go to a facility, and there's all that guilt and emotion and things. This is where a palliative care team can be helpful. You're respected as the center point of your healthcare. It's not my business what choices you make. It's your decision. And that's where we want to put the ownership back on you. And a safe place to discuss hard things. Many of my patients come in and they say, I don't want to be placed. I don't want you to give up on me ever. But the fact is, we don't always have control of our illness. We might not have all the resources to fully have our needs met, our loved ones' needs met in the home. And we have to, find other resources. And that's a safe place to talk about that. So we're available at any stage of illness. We're delivered in-home, outpatient, in the hospital. And palliative care is an evolving practice. So some insurances pay for it. A lot of insurance will pay for the provider, the nurse practitioner, or the physician, and not the other parts, the social worker, chaplain. So sometimes that in-home programs or outpatient programs, they can kind of give you some resources to fill in those gaps. Like I said, I can't read the slides real well. And then, so for my program specifically, we have philanthropic support. So I'm paid by a nonprofit donations, and then the providers through the medical system. Thanks. So hospice, as I said, palliative care is the big picture. Hospice is one part of that. This is an interdisciplinary support, same as palliative care, but the goal is really to provide comfort and care that's comfort focused rather than curative. So once you go on hospice, you're not going to one outpatient doctor to another. You're not treating illnesses like cancer in terms of curative focused treatment. For patients that have Alzheimer's, dementia, Parkinson's, ALS, they're not doing things that will try to be curative focus, life prolonging focus, as much as what can we do to simplify things in the home, make it easier for the patient, more comfortable, make it easier for the caregiver. With hospice, because it's a very specific designed benefit that is covered by insurance, once you go on to hospice, all of your insurance filters through the hospice system. You're able to get a lot more services. They're sort of like the one-stop shop where you get the medication, the equipment, like a hospital bed, commode, or Hoyer lift, things that you might need. So it provides a lot of resources. You have a nurse coming into the home, you have a doctor or nurse practitioner oversight, chaplain, social worker, volunteer, bath aid, a lot of different resources that are coming to you. And then after the person dies, they would have bereavement care. And this is again, it's not focused on the outpatient going and finding things, going back to the hospital, finding out what's wrong, trying to get answers, looking at labs and numbers. It's really saying, let us simplify. And what I find with patients that have dementia or Parkinson's, some of the neurological issues, that it just becomes really burdensome on the family and on the patient. And I see patients that are really weak and can't get out of the house, and they're trying to figure out how to navigate, like, really complicated transportation. Or today somebody was telling me they had 4 people putting their loved one into a car and taking out just to go see the primary care physician. When you have that level of functional decline, do we really want to be focusing on getting out and getting all the answers and trying to preserve a life that is clearly, not functioning and declining, and we're in the process of saying goodbye? Or do we want to spend that time really focusing on what's important? Like, I wrote some notes when Terry was talking, sitting with your family, having friends come, looking at the garden, things like that, where the peace of mind to have care coming into the home when it's the end stage is just beautiful. Death can be a very beautiful experience, even as we're saying goodbye. So the benefit of hospice care comes to you in the home. You have 24/7 crisis support. So somebody falls, your loved one falls, or having severe pain or other symptoms, you call hospice. They usually have a nurse come over within an hour, within a couple hours. So you're not calling 911, rushing to the emergency room, sitting in the waiting, the emergency department for 12 hours waiting for the doctors just to be admitted, get poked and prodded and figure out, oh, I'm here because I have pain, and now all of a sudden I'm getting treated for my heart and my lung condition, and it's just a lot. So it's really kind of simplifying things, providing comfort. There's less risk of infection because you're not jumping around to doctors and nurses. I'm not nurse hospitals. And again, you have the supplies and the medical equipment. And it's just less stress for the patient and the caregiver. I will say that palliative care is also less stress because you have that extra support overall to help align your goals and have better quality of life. The hospice really helps as well because with the care becoming simplified, the caregiver and the patient don't have to just be focused in so many areas when it's like, the ship is starting to sink and there's holes, we're trying to plug them, and it's not working. And I think that's one of the hardest part about caregiving, again, is those transitions that we're saying goodbye on a regular basis. And when we fight that, it doesn't stop the goodbye. It just stops us being conscious and aware and processing through it. And it makes it a lot harder. So hospice criteria, it's a very specific benefit paid for by Medicare. People can have private insurances also, but Medicare sort of set that guideline in America. Usually your diagnosis is 6 months or less without curative focused treatment. That's not a hard line. A lot of times patients with dementia or other neurological issues go on hospice much sooner because it makes sense to simplify the care. After 6 months, you get reevaluated. And I've had patients on hospice 2 or 3 years. There's times where they graduate from hospice, they don't meet criteria, so they go off. But then if they have additional decline or changes, then they can go back on. And it's paid for by Medicare or your insurance. How do I know what service to ask for? We talk to your healthcare provider about which option you think is what they think is best, and also really hone in to yourself, whether your loved one's able to make those decisions or the caregiver's in the seat where they're making the decisions. Really getting honest with yourself, like, does it make sense for 4 family members to take my husband to the doctor to get blood pressure medications? Or would it be better to spend all of that energy sitting around the house, having a cup of tea, having a family visit, doing, songs or sharing memories or, reading books? What is most important in there? The surprise question is a really good question to catch doctors off guard, because a lot of times they don't want to tell us the truth, not because they don't care, but because they're not trained to do that. They're there to cure, to focus on what the next step is in the treatment. And so sometimes they'll continue to prescribe, they'll continue to do the testing, give you treatment options, and not really look at the big picture. So the surprise question is where you would say, do you expect my loved one to be alive by next Christmas? And if they say, no, I don't think so, do you think they'd be alive in the next 3 months? Well, probably, but it takes the pressure off the doctor because you're not saying, tell me, you're saying, give me, give me an idea. And when they don't feel like they have to point to, yes, you have 6 months or less, when it's just more of a conversation, it makes it easier. It puts their guard down. And it also is a little bit easier for you to process that information that maybe grandma will be alive by next Christmas, but maybe they won't. We don't know. But if there's a chance that maybe we don't think she'll be alive, then what do we want to do with the time that we have? Do we want to go into a palliative care model where you get that extra support as you're going through treatments, or do you want to focus more on hospice and staying at home and being comfortable? I forgot to mention that hospice can be provided in home, in a facility, even in a hospital. So.
And I love everything that you shared with us. Those questions, I'm a big believer in ask the questions, right? And the ones that you've given, those are great ones. I'm wondering if before we go on to the next session, we do have uh, a comment that landed in the chat that I'm going to bring up to you, but also for our family caregiver authors to kind of respond to what they heard, how it kind of impacted your own lives. But before we go to you, let me share this. Someone in the chat made a comment that it's very difficult to find palliative care for patients who are not mobile. Any thoughts on that?
Well, COVID has been a rough time for a lot of people. One of the gifts of COVID is that the shift for telemedicine has been astronomical. And I would say about 90% of my patients are doing televisits where we're doing Zoom with the whole team and the caregiver and the patient. And so we have a lot of bedridden patients. Palliative care is also provided in the home. So you would have a nurse or a nurse practitioner usually come to you. So it can be provided that way. It's not as extensive as hospice, and some of the insurance don't pay for it. So it's sort of like a loss leader model where I'll put you on palliative care now and I'll come monthly to see you, knowing that at some point you'll switch to hospice, and then, then they get the benefit, the profit of that or whatever. So um, palliative care is really, if you're bedridden and you need your care in the home and you're not ready for hospice, palliative care is a really, really essential benefit.
Thank you. Thank you. And please, if you have any other questions or comments, drop them into the chat and we will bring them up. Shanice, Tanya, Terry, any thoughts on what you heard? Go ahead, Tanya.
Yeah, so, and that was amazing. I wish I would have known about all of this because prior to when my mom was really ill, there were a lot of things that I didn't understand. And I was making a bunch of notes for my friends who are now in a position where I was. I had heard the term palliative care, but I never understood it. No one ever took the time to explain it to me. And I 100% understand. My mom was going to the doctor 4 and 5 times a week, different doctors. She had a kidney doctor, a liver doctor, a heart doctor. And I had no idea. I had no understanding of anything, and getting explanations from the doctors. I mean, honestly, I was so frustrated. Having someone like you would have been such a blessing because now, when looking back on it, there was so much that could have been done or done differently, that it would have made a difference in her pain levels and her all the things that she was dealing with. And I just really appreciate this from you because this is golden information. Thank you.
Thank you.
Yeah. And just so everyone knows, we will be sending out a replay and we'll include the slides so that you can take your time reading all of that incredible information. Thank you, Tanya. And Shanice, were you going to say something? You looked like.
Oh yeah, I was just going to add the benefits of hospice for me. I truly appreciated having like I said, I was the primary care provider, and my grandmother experienced sundowners very, very bad. And in the middle of a crisis, being able to pick up the phone, I didn't gave the lorazepam, I've given this, help me. What else can I do to calm her down? So to be able to have that life, like I felt like it was a lifeline. They knew me. They knew typically the hours of the night I would call. It was such a great benefit because if not, I'm not going to get a doctor at 3 o'clock in the morning, by calling an office. Another thing of hospice that I appreciated, I think we were authorized for maybe like 4 hours of respite, like a month, where I could have, like, they would send a care provider to come and sit with her. So I would try to stack. Fortunately, I got a great relationship with the provider that they sent, and she would come and I would use that time to go and run and do my grocery shopping. So this is before we had Instacart and all of those things, but it allowed me to do that one task that was really essential but was very difficult, if I didn't have anyone to come sit with her. Having the doctors come in the home definitely alleviated having to transfer into a car to get her to a doctor's appointment, picking up prescriptions. They would call them in, they would be ready, and that care provider could go pick them up, or I was able to go pick them up. The supplies that were needed, having that all on hand, was a true benefit for sure. And you hear hospice and you think scary. Oh, that's the end. When we enrolled her in hospice, it wasn't quite there yet, but the benefits of the resources that hospice has to offer was invaluable.
I think hospice, that's so wonderful, all the stuff you're saying. Um, I think hospice gets a bad rap because most people don't start hospice until the last 10 days or so of a person's life, so they die early. But the studies show that people that are on hospice earlier do a lot better. They live longer than people in the same cohort that aren't on hospice, and even with palliative care. So it's a really rich benefit that just because people don't want to talk about dying, or don't want to go there, or don't want to give up, they send that away when the benefit is just so much, and the stress on the caregiver is so relieved. I want to hear from everybody. It reminded me of something. Yesterday I did an intake, and I was on the phone for 45 minutes with this woman who was just devastated. Her husband's been in the hospital like 10 times in 3 or 4 months. And she just was just unbelievable. Guy has Parkinson's, a lot of physical stuff, a lot of behavioral stuff. I sat with her for 45 minutes on Zoom and just let her talk, 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 talk. I gave very few recommendations. As soon as I finished talking this much, she went, and just that, like, that told me everything, that she was carrying the weight of the world on her shoulders and she had nobody to talk to. And she said, "You don't think I'm crazy?" And I said, "No, I don't think you're crazy." But when you're a caregiver, when you have no feedback and you hear all these different, the only feedback you're getting is doctors and people out there that aren't treating you as the whole person, as the whole family, they don't get it. And that's why people get burned out.
Yeah, definitely. Terry, did you want to add
Yeah,
anything?
I'll just add really quick. I want to reiterate, and gosh, it's just such amazing information because I had no idea what palliative care was. I'd heard it before, but I didn't realize that hospice was a part of it. So that was just amazing. Thank you. We were very fortunate to work with the Council on Aging. My mom lived in Cincinnati, and they have a wonderful organization, and so they were able to initially bring in nurses and physical therapists, and so I think maybe that's what they had brought in for her. They never used that word, but it was along those lines as my mom started to decline. Um, but one of the gifts that I found of hospice was the relationships that were formed and how compassionate and caring these people were that are involved in the hospice. Because when I elected to sleep on the couch and stay with my mom in the hospice room when she was finally moved from her place, her home, to the hospice facility. Um, and there was this nurse that would come in at 3 a.m. and I would my eyes would open because I would sense somebody had walked into the room, and she would bring a warm heated blanket and lay it over me. And then I'd wake up and I'd be like, oh, that feels so good. Thank you. And she was like, oh, I just want to make sure you're warm and taken care of. You're here with your mom the whole time. And I just thought that was such a gift. So, I mean, again, there was so much compassion, and it just, it was just very heart touching for me. So thanks.
That's beautiful, Terry. That is so beautiful. And in the comments, in the chat, go ahead and comment if you learned something new. What was it? What really kind of stands out for you here? We do have a question from the chat, and someone is asking, is there a time limit on hospice that Medicare will cover?
Well, again, it's a 6-month or less initial, and with Alzheimer's, Parkinson's, some of the neurological ones, it's really hard to gauge how long a person has. So you have the first 6 months. If a person is still living, they still qualify based on their needs, based on their goals. After 6 months, they recertify. So they do an assessment. They say, do you meet criteria? And you can continue to recertify. I've had patients on hospice for 2 to 3 years. I work for a special organization where we're for the industry members, Motion Picture Television Fund. So it's a very supportive community. I'm paid for by donations, there's no billing involved. So I stay involved with my patients even when they go on hospice. But just seeing them go through it, just having that extra support. We have one patient the wife has advanced Alzheimer's, on hospice for 2 years. She graduated out of it, that she wasn't dying. So it was about 2 years, probably, the hospice was really questioning. They took her off. She's on palliative care again. And we're pretty clear that if we get to this place, we've already identified with our palliative care doctor, once we get here, we're going to get a reevaluation of hospice. So it's not, you get it and then that's it. You used it, you're done. It's about reevaluating. And sometimes people do go on and off. And other people, they'll be on hospice and then they need some sort of procedure that they say, yeah, there is this new clinical trial I want to do. So let's go off hospice and then you can come back on when you're ready.
Okay. So what I think we're going to do now, because as we all know, we had a few tech glitches starting out. We the tech gremlins are still with us, and our next expert, Frank Cunningham, unfortunately has not been able to. He's fought the good fight, but the gremlins are still winning, and we don't have him yet. So what we're going to do, Frank is an elder care and placement specialist, and he was going to really kind of talk from a personal level because he's caring for his wife who has advanced stages of Alzheimer's, but also a professional level. He helps people find the right placements for their loved ones, and he knows how to find the dollars to actually fund what it is that you need. So, a great resource. We do not have him here with us tonight, but he graciously shared his slides with us, and Anne has graciously agreed to go through them. She's also an expert in this kind of an arena. So what we're going to do is go to Anne, and then we'll bring everybody back again and have a little more of a chat. Again, in the chat, please comment or ask your questions, and we will take those at the end. So, Anne, once again, thank you so much.
I'm back. Just a selfish little plug here. I have a TikTok account and I don't get paid for it. It's completely free, but I've been doing these little mini TikToks about all the topics that we're discussing, just because I find that I'm saying the same things over and over, and caregivers, there's just so much need that they're not hearing, they're not getting the messaging. And so I thought maybe if it's a central place, if it's valuable to people. So if you're interested in that, you can email me or ask Paulina. So part of palliative care, like I said, we're available at any stage of illness. And a lot of my patients want to stay at home. The caregiving burden isn't too hard in the beginning stages. So they're doing it and they're doing fine and they're getting the supports around them. But as people start to transition to more physical care needs, a lot of times caregivers will neglect their own medical issues. And then all of a sudden, one lift too much. And I know you all know this. You lifting or moving, and then you hurt your own back or you hurt something. And then all of a sudden you're not able to do the same type of care that you were before. So as the care needs shift, we start looking at what other supports can be found. In-home caregiving is extremely expensive. I'm sure I'm speaking to the choir. Right now, I think the going rate for an agency that's licensed, bonded, does the payroll and things, it's about $40 an hour for a caregiver, which I don't know about most people, but for me, that would be completely unaffordable if I needed full-time care. So at some point, you move from doing it on my own, hiring a little bit of caregiving here and there. Now I need more structured hours. And now it's just getting bigger and bigger where I can't do it on my own. So we start to consider, when do you think placement might be a good idea? We're looking at the quality of life. Who is the patient, the person? What's important to them? A lot of times when we think that I have to take care of my loved one at home, I promised them, it was my marriage vows, I would never put them into a facility. But the other side of it is the patient themselves, your loved one. Are they getting the quality of life care? Not that you don't want to give it, but if I'm taking care of a physical body, I'm taking care of the house, the bills, all the different things that we have to do to keep up a life, I probably don't have much energy to do the activities, the socialization, to have people come over. And so it's very isolating for the caregiver. We don't always think about for the loved one as well. So finding placement could be an excellent way to have more of a social activities, cognitive stimulation in a facility. I get to go back to being the loved one, to be the family member, not the caregiver. So now, because I'm taking care of myself, my loved one's getting care at the place. Now we can go back to having that loving social relationship. So it can be very valuable that way. A lot less stress for the patient and the caregiver because you have professionals that know how to care. In California, there's boarding cares, like a small family home, usually 4 to 6 patients per, a home that you might see in your neighborhood, with 2 staff there 24/7, and they know how to take care of loved ones. So you can come in and be the assistant, but you don't have to juggle all the stuff that you're juggling. And, just the physical care alone can be really tough. The support, the medication management, the physical support, the care needs. Sometimes when a person's either living semi-independently, you might be a caregiver that you're going to work and your loved one's at home during the day, or some variation of that. And, just making sure that the medications are done right, the medical needs are in alignment. Those are very difficult things to do when you're juggling a lot of other tasks. So when the medical needs change, that might be a good time, the functional decline. We see that all the time, where if a person is fairly independent, they can be left for a couple of hours, or maybe they can go with me to the grocery store and they're not going to get too agitated if they have Alzheimer's or something. But when they stop being able to do those usual activities and you don't have that extra support to take care of yourself, to take care of business, that's where it's good to start thinking about that. So the different types of facilities, like I said, I know a lot about this. I'm not an absolute professional in it, so I'm not sure what CCRC is, but basically there's different senior type living environments, like a 55 plus or something like that. There's facilities that kind of like apartment buildings, or I guess an in-house apartment building, where you have seniors or people that are ill live there, but they pretty much are able to do their own thing. There might be a kitchen, or some type of like independent living type stuff. But then there's also essential activities, essential meals, There's a lot of times there'll be caregiver and laundry and different things like that available to somebody if they need that, if they want that. So it's pretty much your independence with a little bit of support a la carte, what you need. Assisted living was where a person needs, it's not like they're just going on about their day and they, want that extra support. It's where they're really starting to need it. And usually there's a bottom level of support, like maybe they need help with just meals. So they go regularly to the dining room, or maybe they need help doing their laundry, doing that we call independent activities of daily living. And then as their needs change, they start needing more help. They need medication management. Um, they need assistance maybe getting dressed or going to bed. But throughout the day, they're basically able to do things for themselves. They just need a little bit more check-ins, a little bit more structured care. And then memory care is when a person is unable to be alone. They need, they're unsafe being alone. They need 24/7 care. They're able probably to be ambulatory. They can walk around. They can do some things with support from their caregivers, but if they were alone, they would just be completely lost. So that's where memory care can be important. And that's a tough one, because it's like, when do you sort of pull the trigger between I can handle things at home to where it's really overwhelming. Especially, I have patients that have like Alzheimer's, dementia, Parkinson's, with agitation, aggression, and verbal abuse, and it just can be so stressful for the family member that it's just impossible to give the supportive care that they need, with also keeping them safe from the harm that unintentionally the person with dementia, does. And then the assisted living is typically like a larger facility where you have just a wide range of rooms, or like I said, maybe there's an apartment building, or just a bigger facility with different places to get the support. Residential boarding cares are usually like, in your neighborhood, in my neighborhood, there's homes that are boarding cares that I would never know they were. They're just a normal home. And inside, like I said, it's about 4 to 6 residents to 2 caregivers. Sometimes there's shared rooms, sometimes there's independent rooms. And what's nice about that is for people that are more bedridden, or have memory care where they really need that a lot of extra support, but it's smaller, so they're not getting caught up in the larger systems. It's much more family oriented, and especially if a patient's bedridden, needs a lot of physical care, you have that more immediate assistance with staff. When you're in a larger facility, the care ratio is different, so you might have a staff person to beds. I don't know, like one staff to 20 residents, where at a boarding care, it's one staff to 3 residents. So it's just a different type of facility. It's much more, just hands-on, I guess. The downside of a boarding care would be that there's less variation of socialization or activities, or shopping excursion and things, because you have 2 staff with whatever the milieu or the other patients are. If most people are bedridden, then the care really is focused more on home. If they're mostly memory care, then the whole house kind of operates around whatever the diagnoses are in the home, whatever the needs are. So it's just a choice that you want. Sometimes we have patients that will start out in a larger facility. As they get more ill or more incapacitated, they may move to a boarding care. Hospice goes to any of these facilities. A lot of times we'll have patients that end up going to a boarding care because their needs are so high and they really want that comfort family kind of approach. And then having the hospice there, in addition to that, brings in the medical care. How to pay for placement? That's always the question. Most of the time, placement is paid for privately. I think of it, I never like using seniors and children in the same sentence, but I'm going to do it anyway. But I think of care as if, like a child, if my child was sick, I would take them to the doctor, and the insurance would pay for that. If they needed help taking care of themselves, if I go to work and I need care, I'm going to pay for the caregiving. I'm going to pay for boarding school. I'm going to pay for the care that my loved one needs. And that as we get older, unfortunately, there really isn't much structure in our medical insurance system to pay for the caregiving. That being said, sometimes people buy long-term care insurance, which tends to be really expensive. If you have it, that's a resource that will help pay for private caregiving or board and cares, assisted living facilities. So that's an option. There are caveats to that. So a lot of times people will have an illness, they've never had a caregiver, and then they need it, and they say, well, we want to access the long-term care benefits. The long-term care might say, well, you have to pay it yourself, and then after 3 months or 6 months, your benefit will kick in. So there's some nuances around that. Then the VA is another option to help pay for caregiving or assisted living homes. There is some guidelines around that. You can only have a certain amount of resources, assets. I think, don't quote me, but I think it's around $150,000 of liquid assets. You can own your house and one car. If anything more than that, you would not qualify for certain types of care programs with the VA. It's called aid and attendant, and there's things around that too, in terms of were you a veteran during the war years? Were you in combat? Different things like that. So that's a whole nother animal. But if you have your loved one is a veteran or a spouse of a veteran, it's a really good idea to talk to somebody about that. The VA is a very complicated system, so it's hard to get through that navigation. There's different community legal nonprofits that can help with that. There's lawyers that can help with benefits, finding out if you qualify or not. Reverse mortgages, or even taking like a home loan on your property, those are other ways to pay. I know a lot of times people will say, we worked so hard to have our home and we want to give that to our children. And that's a beautiful thought. But as we've grown, throughout the years, we're living a lot longer and we never anticipated that. So as much as it would be nice to have those resources to give to our children, it may be that we're going to need the money and the resources to pay for the care. So some people choose reverse mortgages, which is you're getting a certain amount of money back. You don't have to give up your home if you run out of funds. You can stay there, but it gives you a little bit of supplemental to help pay for assisted living if you need it. And then Medi-Cal's a tough cookie there, because it's for people that are low income and for community Medi-Cal. And if you have the need where you need placement, there's a different type of Medi-Cal that pays a lot more for rent, or for if you need like a skilled nursing custodial care situation where you have physical needs that require 24-hour skilled nursing, like, RN, LVN, and you can't afford to pay. That's like around $25,000 a month, which is unbelievable. Medi-Cal would kick in to provide that. In California, there are board and care facilities, assisted living that accept Medi-Cal, but they're very hard to find. They're few and far between. They're starting to come up with this Medi-Cal waiver facilities that you could access, but I think they have a hold on it right now because there's such a need and there's not enough resources. So people aren't even able to apply for that Medi-Cal waiver now. So it's tricky business. I would definitely talk to people, see if that's, how to get started on that, if it's even a possibility. But I wouldn't count on Medi-Cal being a resource to pay for care unless it's absolutely necessary, like a skilled nursing home. And also, unfortunately, if you're going to a facility that accepts Medi-Cal, they're probably not as nice as the ones you pay for privately. So sometimes there's that that difficulty where you might be getting the care to pay for the home or the facility, but then you're going to have to bring in either yourself or extra caregiving support to make sure that the needs are met, to make sure that they have that socialization or that extra support, because it can be very lonely and isolated to be in a big facility. And not have that family support. I go and visit people at a skilled nursing facility that has custodial care where the Medi-Cal pays for the people who live there, but it's like a hospital room with 3 beds, so 3 residents are sharing one room with 2 curtains, so you have 3 spaces. So it's not ideal, but it is a resource if you need that. For some reason my slides are low. There we go. So placement agencies can be really, really helpful. I tend to see them as like a real estate agent where you don't have to pay them. If they find you a place and you move in, then the facility will pay the real estate agent, the placement finder, they'll pay part of the rent or something like that. So you'll get a finder's fee. But the benefit of a placement coordinator like Frank, who would have be here, is that they know the facilities. Their goal, their job is to find all the facilities in their area that they can possibly find, vet them for you, and make sure they want to have customers come back to them. So they're looking at the best places. They're also looking with your budget. So if I have $5,000 a month, that's that's what my budget is, they'll be able to show me those things rather than me going to place after place and somebody says, oh, sure, I'll give you that. And now we're going to charge you $7,000 a month, or, they already have those relationships. They have those boundaries, and then they sit down and say, what do you want? I've worked with placement agencies that give a family, a loved one, 3 different places, and they say, well, I can't stand all of the 3. Well, why don't you like the 3? And then that helps narrow down the search. Well, okay, if that's important to you, this is what I've got. So it can be really helpful. They also are very aware of the community care licensing, any violations, any issues, and steer you away from things like that. They also set up tours for you. So again, it's like you could go around town and try to find and talk to your friends and look all these things on your own, but it's really cuts the red tape for you. They introduce you to the different facilities. They already know your budget. They know what type of care you're wanting, and they'll walk with you through the whole process. And if you go to a facility and you say, I don't like it, then you go back to them and they can help be an advocate and problem solve with you. They're free. They get paid by the facility. Yeah, there's something else I was going to say about it, but maybe I'll remember. So that's it.
And that's a lot. So a couple of things. First off, again, Anne, thank you for walking us through that. Really appreciate it. Second, we will include Anne's information regarding her TikTok. We actually put it into the chat. So please go and check her out. Regarding things like how to pay for it, on November 19th, so just a couple days ago, we had a session on balancing the biz of caregiving, right? Everything having to do with the checkbook, the legal, the financial, all of that. So if you didn't get a chance to tap into that, do make sure that you grab the replay and check it out. There's a lot of great information on that. Also, we'll make sure to send Frank's information as well on the replay. We do have another question before we bring everybody back on, or as we bring everybody back on, and it says, I am finishing up an in-home supportive services program and planning to continue with a certified nursing assistant next. I would like to know how I might train for palliative care. I want to educate myself as much as possible. Any thoughts on that?
That's a great question. Just to help, I'm sure a lot of you know, but in-home support services is through Medi-Cal. That's one of the few insurances that will pay for caregiving. So people have to have a certain income asset limit, um, that to qualify for in-home support services, which the hours are given to pay for the caregiving. Sometimes people are over the amount, so they're not quite into poverty, and then they pay what's called a share of cost. So just because your income might be different than a poverty line, still check out if you would qualify for that. But for this person, I really commend you in your education and your work. And I would suggest, if you want to get into palliative care or hospice, there's volunteer opportunities where you become a volunteer to help with bereavement, to help with visits to the patients and the family, and just get experience that way. There are a lot of palliative care and hospice are the paid positions require education. Like, for example, a social worker is bachelor or master's level, a nurse, LVN, CNA. Those require education and certification or licensure. But I would just encourage you to continuing the education and maybe start through the volunteer work to see if it's something you're interested in, something you want to invest in with your career.
Mhm. And thank you. And again, yeah, that is true. What that person is doing, we need more of that, right?
Mm-hmm.
And as caregiver needs continue to escalate, as we have more and more seniors needing more and more care, that's going to be so beneficial, so needed. So thank you to the person who commented there. Um, Another comment, John Oliver. I love John Oliver. Who here loves John Oliver? Yeah, yeah. Okay. So John Oliver did an episode on rampant hospice problems and specifically mentioned SoCal Inland Empire. I live in a nursing home and am an active LTC advocate. Is there a resource for caregivers to learn red flags and irregularities?
Yeah. I have a lot I could say about hospice. Unfortunately, hospice went from being a nonprofit, just a supportive medical care to becoming a profit system. I spoke to somebody in Florida, and I don't know if it's still true, but there was 5 hospices in the entire state, and they didn't make profit. In California, Southern California, it is awful. It's like used car salesmen coming at people. I had a patient in the ICU, and somehow a hospice company slipped in and was talking to them about going on hospice before the doctor even said anything. And I was like, get the heck out of here. So yes, it's a tough thing. Now I got on a tangent. What's the question again?
You're saying, is there a resource for
Hmm.
caregivers to learn the red flags and irregularities?
Um, I would say Department of Health, and maybe some of the caregivers here also know, but I'd say Department of Health, if you're in a facility, there's community care licensing. Adult Protective Services is a resource through the state, any state, that helps protect seniors. Part of Adult Protective Services is ombudsman, and those are patient advocates that you can call on if you're in a facility. You will usually, if a report or you feel like you need extra advocacy or protection, you would go to the ombudsman, and they are a wonderful resource to help advocate for you, and to see if there are red flags, how to walk through that.
Yeah, and I'm actually going to mention here, we're going to put it in the chat. USC has a Center for Elder Justice, and we will put the URL there in the chat. Tap into that. They have so many resources there, and I would bet what you're looking for is there. Uh, so then we have another question. Are life-saving medications stopped once someone goes on hospice? Great
It's
questions.
a Yeah, it's a really good question. Not necessarily. We have patients that you're focusing on the comfort. So yes, they're patient like for example, if my husband ever went on hospice, we probably wouldn't continue chemotherapy or the medications that are preserving his life. However, if it's something that would be more painful to stop, you might not need blood pressure medications or cholesterol pills or things that aren't really going to make that big of a difference. But if there's certain medications that are keeping you comfortable, that if you didn't have it, it would cause you pain or suffering, then yes, the hospice would continue that. Antibiotics are always a big question. If a person has some type of infection, obviously they're going to be extremely uncomfortable. And so even though it's sort of a curative or life prolonging medication, it's also helping people with symptom management. So yes, it would be a conversation with the hospice.
Yeah. And we have about 10-15 minutes left. So I want to make sure if you've got a question and you've not yet put it into the chat and you want to get an answer, please do so. And we will make sure we get that done. But I thought it might be interesting for us to all go around and maybe share our biggest aha or our what we think is the takeaway that we think folks ought to focus on from this session. You want to do that round robin and talk a little bit about that? Who's gonna go first? Terry, you're nodding your head like
Yeah, I'll go. Yeah, I think my biggest takeaway, well, one, I learned so much. Again, it's just been so informative. Things that I wished I'd have known then that I now know. But I think my personal opinion on hospice has remained the same after this, and actually more so, in that it really does provide such an opportunity for. I loved what Anne had said about when you transition, or the patient transitions into hospice. It gives you, the caregiver, an opportunity to move from caregiver to just family, to just a loved one, and to be able to, because then it was almost like this sigh of relief, which I felt selfish about, but I was like, oh my gosh, okay, I can just sit here and love her. I can just sit and hold her hand and sing those songs and do whatever it is. Mom, what kind of food would you like today? What can I bring you? How can I bring you some joy? um, there was a therapy dog. I was once a therapy dog team with my dog. We volunteered at schools, but a therapy dog came in, and oh my, like, her pure joy. My son brought his dog to see her, and just be able to, for her to experience that, all that joy in her final few weeks of life it was just a gift. So I was very appreciative of that was the way she transitioned out of this life.
It's funny because we, as caregivers, we're thinking about our side, and I want to do this for my person. These are all the reasons why I, shouldn't or should, but we don't think about the patient. And when I work with patients, the other day I was working with somebody and we said, "How are you doing, mom?" Who's the patient? Daughter's here, perfect caregiver. And the patient's like, "I am so sick of having this mother." And it's like, I think she would be happier with some professionals so she could have a daughter again. But she's just like, "This mother is so overbearing." And I just had to laugh because we don't always think about, if we were in that position, how we would feel, like my daughter changing my butt and, telling me what to do and when to take my medication. So I like, yeah, you both get to be the family again. So
that's
My
great.
mom said that to me so much. She said that to me all the time about, I'm tired of you being my mother. But I I think the fact that we always talk about being family caregivers, we feel alone, and that there are palliative care consultants like you, Anne. For me, that I cannot wait to share all of this information with my friends who are dealing with this, because they're calling me asking me questions about things I have no idea about that. And For me, the biggest thing is knowing that there are people out there like you that actually have the interest of the family and the patient, not just the patient. Um, you know, I think that that is just amazing. I just can't get over how much I wish I would have known. But I'm very excited to share with others. So thank you.
When I talk about palliative care, I often say that family is the second patient and sometimes they're the first, because when the family is doing well, the patient does a lot better. And it really is a family, it's a whole family dynamic. It's a family illness.
Absolutely. And I would say, and from the presentation that you shared for Frank, um, I guess the key takeaway for me, because I lived having to make that type of decision for placement, was it's okay if plans change and to give yourself grace. One of those identifiers of knowing, hey, it might be time to actually place your loved one in a facility or a place where they can get some additional support was when you have the inability to care for yourself or take care of business. I had noticed I wasn't sleeping. The house, I hadn't been able to maintain it like I should, just doing laundry, like the basic things. And once I did place her in the facility, that sigh of relief, which I also too felt guilty about, Terry, you know, it's it just did so much better for me to even process all the things that are changing so rapidly as well right in front of you. So if I could give any advice to other caregivers, it would be to give yourself grace.
I love that.
No,
And I
that's a
think
good
we don't do enough of that.
no.
Mhm.
No. And I will just piggyback on my little takeaway. It's exactly what Terry said because too often we we look at this in terms of I should be able to take care of that person, right? And I'm a bad daughter, bad son if I don't, instead of looking at it from a different lens. And I know in my own situation, being primary family caregiver for a mom and a younger sister, both diagnosed with paranoid schizophrenia, I was not the best for them. In caring for them, I was I had become a bit of a danger to them, to myself, and the best thing was for me to get out of that situation, which when I did, I became a better sister. I became a better daughter. And I can't stress enough that to put the emphasis on what that person really needs versus what you think you ought to be doing, right?
Mhm.
So thank you for that. And we have another question here. Now,
Can I
I'm
just
going to
say
ask,
one thing?
yeah, 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 sure.
Just let me say something real quick with that. Also, a lot of times we have this idea that in my marriage vows, I said I would never put you into a home. But now I'm in this spot where my husband has severe Alzheimer's and I'm, going bonkers. If we had asked my husband, would you want your wife to have pulled out all her hair and have, bumps and bruises and crying all night? Is that the wife that you would want, that, yes, by any means stay in the home? Or would your loving husband 10, 20 years ago say, I wouldn't want that? But when we say, I want to stay in the home, it's like, I want to stay in the home the way I am now. If I knew, if I was able to speak for myself, I wouldn't want to put that on my loved one at all. But we hear the words and we think that's what we have to do.
Yeah. And just to piggyback on that, again, grab that replay to the business of caregiving from the 19th of November because it spoke to estate planning and basically when is the time to do that? It's when you and the care recipient are at a place where they can share what it is that they want, right? You can have these conversations and put them on paper so that your emotions won't play a role as much when the time actually comes, right? So, and no care recipient wants their loved one to do that, to sacrifice themselves. I know I would feel horrible, right? All of us here would feel horrible knowing that someone else is completely sacrificing their life for us. I don't think anybody really wants that. So thank you, Ann. That's totally, totally true. And we have one more question. I'm going to ask it, but again, we put in the chat the replay for the business session, uh, because I think this might belong there, but I'm going to ask it anyway. How does Medicare hospice compare with private long-term insurance hospice coverage? In general, which is better tax-wise? I have to pay taxes last year on long-term care 1099 reimbursement. Is that something you might have a comment on,
Yeah,
or is
well,
it?
so long-term care is a separate thing. Medical care is medical insurance. So Medicare pays for medical care, which is hospice. Hospice is a medical benefit for doctor, nurse, um, other CNA, bath aid, a lot of different services to manage and make a person comfortable. Long-term care is like a special focus on this is what I've done in as insurance in case I need a caregiver. So long-term care is not paying for medical care. It's paying for, I need somebody to provide the day-to-day care, whether it's, the independent living day, going shopping, doing those types of things, cleaning the house, or the care of the activities of daily living, feeding, bathing, dressing, keeping them company. So that's long-term care. Hospice is the medical Medicare stuff.
Okay. Okay. And yeah, and definitely for that person, we put it into the chat. Tap into the November 19th session. I think what you're looking for will be there as well. All right. Now, Anne, you didn't get a chance to give your final takeaways.
Well, one thing I mean, all the caregivers had such beautiful stories that really kind of fleshed out the what I talked about. I really loved what Shanice was saying about the transitions and having grace, and just realizing that we don't have to have all the answers. We're just putting one foot in front of the other. And I think what Shanice was the one that said about, that we can go backwards. You can try hospice, and if it doesn't work, you can go back to palliative care. If you don't like palliative care, you don't have to do that. If you want to try out placement, sometimes these community facilities will do respite. So you can go for a couple of weeks or 3 weeks, see how it is. If you don't like it, you can come back home. So just having that patience with yourself, being open to having these discussions when you're not in a crisis, so you're making more logical decisions, and then seeing all these lovely ladies here, how they navigated it. I think it's really important to tell your own story, read stories of other people, so that you find that we're all in this together. And things, we may feel like my situation is unique, but you'll find bits and pieces. I've found bits and pieces from everybody here that it might not all be relevant to my situation, but there's some that are now, and there's some that will be later. And like what Tanya is saying, there's some things that I'm collecting for friends or my patients in the future that may need that information.
Mm-hmm. Yeah, that is wonderful. And we don't have to know it all, right? Just need the, the next step. One size does not fit all. There is no playbook. If there is, I wish somebody would share it, right? There is no magic bullet. So this is great. And the more that you can tap into different uh, support services, right? So I know that Los Angeles Caregiver Resource Center has actual support groups that you are a client of ours, and so they are confidential. You enter into them, and it's so beneficial to talk to people who are walking similar paths as you. The worst thing anyone can do is stuff it down and put on that cape and pretend you're some kind of superhero and you can do it all, right? That that I often say silence and stuffing it down, that will suffocate, right? It just will suffocate. Doesn't serve you, doesn't serve your care recipient. All right, so we have come to the end of this. We do not have any more questions. You all, I can't thank you enough. This has been a wonderful, wonderful session, one that is a challenge to even talk about. So all of you, thank you for bringing your expertise, bringing your stories, having the courage to share with everyone. It has been invaluable. Um, Everyone listening, please tap into the Los Angeles CRC um, website. You'll see the URL on the screen pop up, losangelescrc.usc.edu. You will find so many free resources. You can sign up for our newsletter. You'll be kept abreast of all of these workshops and support groups that we have to offer. And just in case you didn't sign up for all of the COM sessions, uh, sign up for the newsletter and you will be able to get those replays. We have one more session left in the month of November for COM, and it is November 26th. This session is going to be all in Spanish, and it's going to actually focus on culture, on the Hispanic culture and how that plays a role in a caregiver's life, right? So often our families, right, our traditions, our beliefs, they impact how our caregiver journey goes. And we're going to be focusing on this one all in Spanish for the Hispanic community. So please be sure to sign up for that. You will see it at the bottom of your screen. It's scrolling. Also remember, if you want to put your name in the hat for the random drawing for the Caregiver Chronicles book, please do share on your social, tag us, email us with a screenshot. You've got the email there on the screen, and we will enter your name, and hopefully you will be the one we pick for our random drawing. Now, I've said it on every single session. I'm going to say it again. You all matter. You matter not because you're a caregiver, but you matter because you just are. And here at the Los Angeles Caregiver Resource Center, we want to remind you of that. And that's why we bring you so many of these sessions to help you not only navigate your caregiver journey, but just to make you yourself, your life a little bit easier. And we hope we've done that. We know we've done that with this session tonight for sure. So thank you again to everyone here and to those watching, listening. Until we see you again, on behalf of USC and the Los Angeles Family Caregiver Resource Center, I'm Paulina Milana, and I thank you all for joining us. Good night.
Thank you.